This is Charlie. Many of the people in this room were involved in his care as he was undergoing treatment at Lady Salento for hot oil burns covering 35% of his total body surface area. Recovery from a burn of this severity is always remarkable, but one aspect of Charlie's management in particular made his case stand out.
We treated him in a bit of a different way from normal, in that we have been using a lot of what we call negative pressure wound therapy.
The successful use of negative pressure wound therapy in Charlie's case underscored the potential for negative pressure in the management of pediatric burns.
Charlie was very much a world first in treating a patient so small with such a large burn with negative pressure wound therapy, and the results were so good that will lead us on to a huge trial in many kids coming to this unit next year.
That trial is what I'll be talking to you about today. Hi, my name is Cody Freer, and I'm a medical student and PhD candidate. With your help, I'd like to conduct a randomized control trial investigating the effect of negative pressure wound therapy on reepithelialization, pain, and wound progression in acute pediatric burns. It will be a study of negative pressure wound therapy as a treatment for acute burns in children, or if you liked contrived acronyms as much as I do, SONATA in C. This video is intended to give you a short introduction to the project and run through the study protocol and endpoints. I'm sorry that I can't be there to give you this presentation in person, but I'm in the US right now spending time with family and trying to avoid seeing this face as much as possible. But I welcome any feedback you might have and should be Skyping in at the end of the presentation to answer all your questions. I'll begin with a very brief background on negative pressure wound therapy. Negative pressure wound therapy is a non-invasive therapy that involves the use of a suction device to draw tissue fluid from a wound by establishing a vacuum through sterilized occlusive dressing over the wound site. Since it was first developed for clinical use in the 1990s, it has been increasingly used in the context of skin grafting, diabetic ulcers, and open abdominal cavities. Although it was first identified as a potentially useful addition to standard burns therapy shortly after its creation, the literature on its efficacy in the setting remains very limited. A 2014 Cochrane review identified only one RCT analyzing the use of negative pressure wound therapy in burn wounds, and this study was found to be methodologically weak and poorly reported. Nevertheless, multiple authors have described the technology's use in burns management, including a 2017 study that found it to be safe and effective in pediatric burns. And the use of negative pressure wound therapy in the treatment of partial thickness burns was approved by the US Food and Drug Administration in 2003 and the Australian Therapeutic Goods Administration in 2013. Additionally, a local pilot study found that pain scores were notably lower in patients treated with negative pressure wound therapy as opposed to standard treatment. These preliminary results provided convincing evidence to progress the trial to a fully powered RCT. But before we get to the study design, you might be thinking,
How does it work?
There are several mechanisms by which negative pressure wound therapy is hypothesized to improve the healing process and limit or halt burn wound progression. First, it is known to induce an interstitial gradient shift causing a reduction in edema, with a possible secondary increase in dermal perfusion. It is also believed to produce a mechanical stress that might have a stimulatory effect on cellular activity, including angiogenesis. The moist environment it generates may be advantageous by providing an ideal setting for reepithelialization and preventing tissue desiccation. Finally, it is possible that negative pressure wound therapy improves healing by removing acute inflammatory mediators, such as free radicals and cytokines involved in burn wound progression. Now that that's out of the way, your next question is probably,
So, what's the plan? Right.
Funding for this project will be provided by Smith & Nephew, and we will be using their Renesis Go negative pressure wound therapy devices. We aim to recruit a minimum of 68 patients for the trial, with at least 34 in each treatment arm. Treating surgical registrars will be asked to help determine suitability for enrollment in the study. All patients presenting to the Lady Salento Emergency Department or Burn Center will be considered for eligibility, regardless of burn depth or mechanism, provided the following exclusion criteria do not apply. 1. TBSA of 5% or greater. 2. Presentation to the hospital over 7 days post-burn. 3. Trivial burns. 4. Electric burns. 5. Facial burns. And 6. Patients older than 16 years of age. Patients with caregiver consent will be randomized to either the control group or the intervention group. Patients in the control group will receive routine care. The intervention group will have their wounds dressed with the same dressing combinations as the control group, in addition to receiving negative pressure wound therapy from a treating nurse using the Renesis Go device. Dressings, with or without negative pressure depending on group allocation, will be changed every 3 days at the burn center. Distraction techniques and analgesia will be used as per unit policy during dressing changes. Wound fluid will be collected from negative pressure wound therapy devices if available at all dressing changes for analysis of wound healing and inflammatory mediators. Patients in the intervention group will continue to undergo negative pressure wound therapy until 95% re-epithelialized. All patients will continue to receive standard therapy dressings until 95% re-epithelialized, unless they require skin grafting or an infection develops. Data will still be collected for patients who require grafting or develop an infection, and these will be included in the final analysis.
Your analysis, Bob.
What is it?
Not what is it, Captain. What are they?
Our primary endpoint is time to re-epithelialization. Percentage re-epithelialization will be assessed at every clinical visit via 3 methods. 1. Clinical judgment from the consultant. 2. Use of a 3D camera and analysis on the Dermapix software program. And 3. Blinded review of photographs by a panel of 3 burn surgeons. Pain is one of our secondary endpoints. It will be assessed during dressing changes in clinic and at home between dressing changes. A variety of measures will be employed to evaluate pain and distress, including 1. The nurse's observational rating of the participant's pain and distress using the FLAC scale. 2. The participant's self-report of pain intensity using the revised FACES pain scale if the participant is aged 4 years or older. 3. The participant's self-report if aged 8 years or older, or the parent's report of the participant's pain intensity using the visual analog scale. 4. Pulse rate and respiratory rate of the participant taken immediately prior to and after dressing changes. And 5. Any analgesic or sedative medications administered to the participant at each dressing change. Other secondary endpoints include resource use and costs, itch, ease of management of dressings, adverse events, and scar and skin assessments if scar management is required after full re-epithelialization of the burn injury. For patients requiring scar management, face-to-face follow-ups will be completed with all participants at 3 and 6 months following full re-epithelialization to conduct a skin and/or scar review in conjunction with occupational therapy. These follow-ups will involve measurements of the scar using ultrasound and 3D photographs, assessment of scar severity with the patient and observer scar assessment scale, and an evaluation of the scar's intensity and effect on quality of life by the Brisbane Burn Scar Impact Profile.
That's about it.
Filled with potential, but thus far poorly researched in the context of acute pediatric burns, negative pressure wound therapy is ripe for a randomized control trial. We hope that at the conclusion of this study, we will be able to definitively measure its impact on healing, wound progression, and pain, and by doing so, inform and perhaps even alter future care so that all patients have a better chance at an outcome as successful as Charlie's.